Okay, so I'm really grateful for the opportunity to talk to you today. I think the most important thing to say is that I'm not an expert. I don't think we are expert with COVID-19, but I can say that we have gathered a huge amount of experience over the last 6 to 8 weeks. As you pointed out, I'm an intensive care physician. I'm based in the James Cook University Hospital in Middlesbrough, which is the tertiary centre. And I think the important thing to say is that although we had warning that COVID was coming, we were preparing for quite some time before it arrived, and still we found that we weren't quite expecting what arrived. And I think some of the case presentations that you've demonstrated previously would support that. So if we can have the next slide, please. Okay. Can that scroll down? Yeah. So I think ultimately we have a new multi-system disorder, and the emphasis is on multi-system. I think we are starting to understand the pathophysiology a lot better, but we are still learning and I think gathering experience rather than expertise. The good thing from a critical care standpoint is that there's been an abundance of shared learning, and I think a lot of what we have learned and how we've prepared both technically and in terms of organisationally, but also clinically, has been the shared learning that has been available from other countries, particularly. So it was obvious in northern Italy, in Lombardy, that the crisis hit them first, and the teams there were very, very generous with their knowledge and their learning. Again, a lot of the Spanish teams. And when COVID hit the UK, we were fortunate in the Northeast that we had a few weeks longer than our southern colleagues to prepare. So critical care units in London seem to have a bigger influx of patients, probably about 2 to 3 weeks before us. So we had time to learn from them. And I think this is a great opportunity for lots of clinicians to come together, but certainly the critical care community across the globe has come together to share learning. The webinars are very, very common. We're having them on almost 2 or 3 a week through our various colleges, the Intensive Care Society, Faculty of Intensive Care Medicine, and the European Society of Intensive Care Medicine, and that has been a huge benefit. We've just moved down to the next slide. I'm just going to concentrate on our main concerns when the COVID crisis emerged. I think from a critical care perspective, capacity in the UK has always been a major problem. And I know that I'm probably speaking to Sudanese colleagues who are more than aware of capacity issues. I think one of our key problems was the fact that we felt that we may be overwhelmed much more quickly than maybe our Italian and Spanish colleagues. So if we just flick back to the last slide. No, up. That's it. You can see that in comparison, the Italian and Spanish colleagues probably have twice the number of critical care beds compared with us. And initially, when we were starting to do our planning, we were hoping to escalate to 4 times our base capacity. And I know in the UK press, there was a lot of emphasis on the availability of ventilators, but have to say it's not the ventilators that are the key issue. It's actually the number of nurses and the medical staff as well, but primarily the number of nurses to look after these patients. If you move down to the next slide, please. It's just a demonstration of the global comparison of deaths. And you can see that at the moment, the UK is sat in amongst the rest of our European colleagues. At the beginning of the crisis, we were reporting hospital deaths only. And over the course of the last week, we've started to report UK deaths in all settings, which include the community and care homes. We breached this week the 20,000 death mark, which was seen to be a marker of how well we were coping. And I suspect by the end of this crisis, our numbers will be the highest in Europe. Next slide, please. The other thing that we can demonstrate is the regional variation, and you can see that the London peak came a little bit sooner. We sit in the northeast and we're tucked into the middle of there, and maybe down in the southwest where the number of people in hospital with COVID is slightly less. This allowed us to, as we peaked a little bit later, to have more time to prepare and also to learn from our London colleagues. Next slide, please. This is basically just gives us our data from yesterday. So at the moment, our total number of UK COVID deaths is in excess of 27,000. And at the moment, we're still having between about 500 and 700 deaths per day. So this is still a significant burden of workload. And I would echo previous speakers who have suggested that our non-COVID work is still present, and people have been presenting late, and certainly in the last week in the UK we are definitely seeing a re-emergence of non-COVID work, particularly emergency work, and people presenting possibly later than they would have done under normal circumstances. Next slide, please. And this is just to show the COBRA data, which is looking at critical care beds with COVID-19 patients. And we peaked around Easter weekend, which was around the 9th through to the 12th of April. And the general trend is downwards. That doesn't mean to say that we have lots of vacant critical care beds. What we've done is we've staffed up with retired and returned nurses who are skilled in critical care but work in other areas. And as we've suggested, we're now cohorting COVID and non-COVID patients, which means that the critical care footprint is still larger than we would normally have. And also, as we've seen the expansion of the non-COVID workload, and hoping to start some of the elective surgeries, some of the cancer patients we have continued to operate on throughout this crisis. So really we are in quite a tricky situation at the moment, although the number of actual COVID-19 patients is declining. Next slide, please. This demonstrates the number of new cases in blue, but also the increased number of testing, which has been a big public priority. And next slide, please. So experientially, this is what we're seeing in our critical care units. Older age patients are doing have worse outcomes. We're seeing predominantly males in an order of probably 75 to 25%. There's a preponderance of patients that are hypertensive, diabetic, with high body mass index, and the Black, Asian and ethnic minorities are overrepresented in our current COVID-19 populations. Our next plan is just to take you through some of our recent intensive care National Audit and Research Centre data. We're just looking at age on admission, and we can see that this is differentiated between male and female, and the male in the thick grey bars are well and truly represented compared with the females. And these are compared with non-COVID, previous viral pneumonias during the years 2017 to 2019.
Sorry, can you see the slide? We can't see that slide.
Next, I think it's the next slide, sorry.
Yeah, thank you.
So you can see the thick grey bars represent the males who are critically ill with COVID-19, compared with the thick blue bars, which are the females. And you can see the overrepresentation of males. Also, you can see the spread of age, and they're compared with case controls of patients that have had that had viral pneumonia between 2017 and 2019. If we move on to the next slide, please. This is just looking at BMI at presentation, and certainly we can see that the number of patients with a BMI in excess of 30 is overrepresented in this particular cohort of COVID-19 patients. Next slide, please. Also, we've talked about the Black, Asian and ethnic minority populations, and compared with local populations based on just a standard census, we can see that the Asian, Black and ethnic minority are overrepresented in the critically ill patients with COVID-19. Next slide, please. And in terms of the number of organ support, obviously there's an excess of patients requiring advanced respiratory support, which is in keeping with what we see in a critical care setting. But as I alluded to earlier, this is a multi-system disorder, so the need for cardiovascular support, both advanced and basic, and renal support are also required, and you can see that the need for renal support is in excess of 20% in this particular data set. And next slide, please. Many people have talked about the different symptoms related to coronavirus, and as I look at this slide, I am now day 19 post-coronavirus, and I can say from a personal perspective that I've probably experienced many of these, and you can see the difference between those with severe and non-severe COVID. With fever, cough and fatigue being predominant features, but you can see there is quite a diversity of presentations. I had abdominal pain, nausea and vomiting, which I hadn't associated with coronavirus. Nonetheless, it just gives you an idea that when you first meet patients, the broad variety of presentations. And next slide, please. And I think one of the misconceptions that we had as intensivists at the early stages of COVID-19 was that we thought that this was just a variant of ARDS, acute respiratory distress syndrome, and we also thought that we've managed this in various guises over the years, and that perhaps we were quite well prepared. And we're not too unused to seeing patients with x-rays as bad as that, but what we were seeing is a slightly different picture, and the low-grade inflammation, lymphopenia, this hypercoagulability which became apparent fairly early on with us, and this heterogeneous microvascular dysfunction, which I still think is probably one of the more complicated areas where we still need additional understanding. Next slide, please. At the onset of the COVID-19 crisis, we were seeing multiple people with severe respiratory failure. They were presenting profoundly hypoxemic, not necessarily particularly dyspneic, and multiple of my colleagues would have said that they'd met patients in the acute front of house setting where they were hypoxic with very low oxygen saturations despite supplemental oxygen, and they were sat using their mobile phones. And what we felt from the message from European colleagues in the beginning was to treat as ARDS, to keep the patients dry and add lots of positive end expiratory pressure. And we quickly realised, as many other people did, including Gattinoni, that this wasn't a homogeneous group of patients. In fact, Gattinoni has suggested that there are actually two different phenotypes, and these two phenotypes actually dictate how we ventilate these patients. He talked about the three different phenomena that contribute to the hypoxemia. So dysregulation of pulmonary perfusion, pulmonary microthrombosis, and then pulmonary edema and collapse, which is more akin to the ARDS type of picture that we know. Two different phenotypes actually we manage in different ways. So the L phenotype is all about being low lung elastance or high compliance, low VQ mismatch, lower recruitability, and limited response to PEEP. Whereas the phenotype H is all about high lung elastance, high right to left shunt, higher recruitability, and higher PEEP. And patients may start as phenotype L, progress or not progress to phenotype H, but it does make a difference to the way that we ventilate these patients. So if we look at the L phenotype to start with, we know that the amount of gas in the lung is near normal. We think that the low VQ mismatch ratio is probably due to loss of the regulation of perfusion and loss of pulmonary hypoxic vasoconstriction. Pulmonary artery pressures tend to be near normal. If you can move to the next slide, please. We also know that the lung weight is just about normal, and if we look at CT scans, if patients are stable enough to have these done, then what seems to happen is you get subpleural distribution of the ground glass densities. And these patients tend to have low lung recruitability, and therefore application of high levels of PEEP probably are not going to help them greatly. If we move on to the next slide, please. The predominant management strategy is to correct hypoxemia, and obviously to start with, non-invasive techniques are probably most ideal. When the Wuhan outbreak started, there was a message that these patients should be intubated soon. And I think once they ran out of ventilators, then we had to look at other strategies. But our London colleagues were very good at using early CPAP and had some good results with their work and shared their work, so that we had a bit more confidence in using non-invasive techniques. Initially, there were some concerns over the use of high flow nasal oxygen, just in terms of aerosol generation, but we have had some success, and obviously many patients will prefer this just in terms of tolerance, and I'll talk to you a little bit about that later. We have several different means of being able to deliver continuous positive airway pressure. And I think one of the key ways that we've dealt with this is actually to deliver CPAP on the ward, which is a new introduction to the acute medical teams based in South Tees. As prior to this, CPAP would only be delivered in a critical care area. Many of the respiratory physicians and acute physicians were very, very comfortable with non-invasive ventilation or BiPAP. And what we've had to do is develop strategies for being able to not only deliver this, but to monitor these patients carefully on the ward. And I think the one take-home message that I would deliver is that careful monitoring is essential, looking for signs of excessive respiratory effort, looking for increased work of breathing, and trying to intervene at the correct stage to try and prevent fatigue, exhaustion, and cardiorespiratory collapse. We know from previous studies anyway that delays in intubation can contribute to increased mortality and morbidity, and it's really important that we are prepared to recognise failure, not just to observe deterioration, but to have a plan B as we initiate non-invasive support. Next slide, please. Can we have the next slide, please?
Yes, okay, we'll do.
This is just to show a high flow nasal device, which we use fairly commonly in lots of patients in critical care. The benefit of is a high flow, also provides humidification and comfort, so that the patient can eat, can drink, and can communicate. There is an aerosol generation, but the range of that aerosol is something in the order of about 45 to 85 centimetres. Obviously, the patient can cough, so the need for full PPE is essential. Move to the next slide, please. And this is our standard technique for delivery of facial CPAP. You can see that the addition to this is a bacterial and viral filter to try and remove viral particles from expired gas. Also the need for oxygen entrainment, and an exhalation port which cannot be covered. But I think in conjunction with this, the need for very careful monitoring. Move on to the next slide, please. You can see that face mask CPAP in this situation, it's quite uncomfortable for many patients. The downside of it is that it creates pressure areas over the bridge of the nose. Patients, if they're claustrophobic, can be slightly overwhelmed by this, so compliance can be an issue. If patients are agitated or delirious, then tolerance can be much, much worse. But the benefit is that you will be able to deliver high flow oxygen, hopefully recruitable lung, reduce the work of breathing, correct hypoxemia, and hopefully try to avert the need for intubation. Next slide, please. And this is just a demonstration of how we could deliver CPAP via a helmet or a hood. We've used these for many years with some success, and the benefit of this is that despite how it looks, the tolerance is better. Patients find it less claustrophobic, surprisingly enough. The downside is that obviously eating, drinking is difficult. And also it can produce some pressure sores underneath the axilla where there's tethering of the mechanism to keep the hood in place. One of the major problems that we developed during the COVID crisis was actually just availability, not only of the helmets, which our manufacturer is in northern Italy, which had been already hit by the COVID crisis. So distribution of that in the initial stages was quite difficult, but also the availability of circuits and consumables, because obviously there was a big surge in requirement from multiple critical care units around the world. Next slide, please. So I've talked a little bit about the non-invasive techniques that you might want to start with for the L-phenotype patients, and then moving on to the H-phenotype patients. These patients tend to be a little bit more akin to treating ARDS patients. The lungs are heavy, edematous, with decreased gas volume and reduced compliance. There's a fraction of the cardiac output which is perfusing non-aerated lungs, so we have a high right to left shunt. The lungs tend to be heavier, but they have an increased recruitability, and this is how we would normally manage patients with ARDS. If we move on to the next slide, please, I'll talk a little bit about the issues in terms of treatment. We move to the next slide, please. So we tend to use higher PEEP, but positive end expiratory pressure obviously causes raised intrathoracic pressure. With raised intrathoracic pressure, venous return decreases, and obviously that has an impact upon cardiac output. Many of these patients are quite dry because of insensible losses from fever, from respiration, but also because of decreased intake, because of breathlessness, nausea, vomiting, and just being generally unwell. So it can compromise hemodynamics. We would have a very low threshold for consideration of prone position ventilation, and this has been one of the mainstays of our treatment for severe hypoxemia with ARDS for some years. So also from ARDS work, there's evidence that neuromuscular blockade can help improve outcome. And our other strategies, which I'm not going to mention in any detail because these are really rescue techniques, which we would use for severe refractory hypoxemia. That would be alveolar recruitment maneuvers, that's manipulation of the ventilator to try and recruit recruitable lung. A technique called airway pressure release ventilation, which is essentially inverse ratio ventilation. And then also, obviously, there's the opportunity for ECMO, which in the UK is in a small number of centres and only for the sickest patients. And I'm not really going to go into any great detail about that. Next slide, please. This came from NICE guidance, and this was a suggestion of how you would initially assess and manage people with hypoxic respiratory failure and COVID. For those in the green category, where they have an acceptable respiratory rate but are at risk of deterioration, but with just the straight administration of oxygen and the need to observe and monitor. For those that are requiring more than 40% oxygen to maintain saturations, then there was a suggestion that you might just give an oxygen boost and then organise senior clinical review. And I think the key issue here is making sure that there is a senior clinical review and that there's early decision making about the treatment strategy as to whether CPAP is appropriate, and where that can be delivered, and then a discussion about a treatment escalation plan, which is TEP. For the red category, for those people who are already in extremis or struggling on arrival, where they, despite maximal facial oxygen therapy, are still hypoxic or are obtunded, then urgent critical care input would be necessary if it was felt this patient was suitable for intubation and ventilation. Next slide, please. The next scheme was actually adapted from a strategy from based in the University College Hospital in London, and it basically just highlights the need for careful monitoring. It's stratified into red, amber and yellow, and essentially it's based on saturations, but also saturations for people with normal respiratory function and saturations for those with COPD. And it gives a scheme for how to look after these people and what to do in terms of their monitoring, their escalation of respiratory support, the need for senior clinical review and the need for intensive care input. And we distributed this to our acute front of house wards that were dealing with the patients as they were admitted. And I think they were finding it quite difficult to know who to escalate. And I think in the beginning, we had lots of discussions about who we felt was appropriate to treat and escalate. And as we had no issues with beds at that time, and we were able to admit many of these patients into our assessment beds in critical care and give them the benefit of very close monitoring and repeated decision making, so that we would make decisions early with clinical colleagues as to whether we felt they would benefit from invasive ventilation. Next slide, please. Many of the COVID-19 resources regarding intubation and ventilation and management of hypoxemic patients have been circulated via the Society of Critical Care Medicine in conjunction with the Surviving Sepsis campaign. I think it's clear that if patients are tolerating supplemental oxygen, have careful monitoring, have highlighted a target oxygen saturations, and they're in a safe place, then they are safe to stay on the ward. What happens next is the recognition of deterioration, which is largely done by the ward team in conjunction with the critical care outreach team using the NEWS2 scores, and then decision making early about the need for endotracheal intubation. In the beginning, we realised that we may be overwhelmed by the number of patients needing intubation. And so we relied very heavily upon our anaesthetic colleagues who worked as intubation teams. And they, as soon as we recognised a patient who required intubation, we would call on their services so that we could coordinate care, but we were not involved with the initial technical issues related to the intubation. That said, they had clear protocols, checklists for rapid sequence induction, and also use of video laryngoscope to try and reduce contamination during the intubation process. Next slide, please. Going back to Gattinoni's work, I'm just going to look at the management of COVID-19 respiratory distress, and highlighted that after intubation, the slight difference in the way that we would ventilate patients depending on their phenotype. And how we recognise these phenotypes is literally just hands-on at the bedside, looking at the ventilator and working out what the ideal PEEP is for this particular patient. The idea is that we protect injured lungs. So what the L-PHENOTYPE, which suggested that lower PEEP is more beneficial, more liberal tidal volumes in the order of 7 to 9 mils per kilo, and to think about prone positioning. In the H-PHENOTYPE, higher PEEP tends to be required to maintain oxygenation. We would aim for about 5 to 7 mils per kilo. And have an early decision regarding prone position ventilation. Next slide, please. This is a summary slide of the techniques for managing patients with COVID-19 and ARDS. Some of the evidence is weak, but certainly what we want to do with the mild ARDS patients is look at maintenance of saturations, think about empiric antibiotics, conservative fluid strategies. For those that are more severe, use of neuromuscular blockers, recruitment manoeuvres, prone position ventilation, and for the very severe needing rescue techniques, we were looking at things like inhaled nitric oxide, if it's available, then referral for ECMO. Moving on to the next slide, please. I'm just going to concentrate for a little while on prone position ventilation, because this has been quite key to success in some of our patients with refractory hypoxemia. Obviously, you can tell from this particular patient that moving patients into the prone position can be tricky, and protection of pressure areas is key to success. Next slide, please. The advantages of prone position ventilation is that we tend to be able to optimize the VQ mismatch that I've demonstrated earlier. We can usually reduce atelectasis and re-recruit de-recruited lung. Being in a prone position, if there are respiratory secretions, which we do see, then sometimes it's almost like postural drainage of secretions. If you ideally position patients, then the diaphragm has better movement, the abdomen floats free, and you can improve the functional residual capacity. In the prone position, the heart sits against the sternum rather than compressing the left lung, so ideally there's more recruitable lung. And you tend to get better distribution of the plateau pressure throughout both lungs in the prone position. Also, you alter the respiratory mechanics, and it allows the lungs to be inflated at lower ventilator pressures, which means that you're less likely to cause ventilator-induced lung injury. Next slide, please. Clearly, it's not that easy for to be able to turn these patients over without causing other risks. And what you're trying to do is mitigate the benefits versus the risk. There's a risk of dislodgement of the ET tube, which in a critically hypoxemic patient can be a disaster. Obviously, a lot of these patients have intravascular devices, central lines, chest drains, dialysis catheters, and there's a potential for dislodgement of those. Monitoring is more difficult, and during the prone position procedure, you are without monitoring for some time. You can cause increase in intracranial pressure, intra-abdominal pressure, intraocular pressure, and obviously the pressure areas I alluded to, facial edema, nerve damage, etc. And if you have a cardiovascularly unstable patient, moving them prone can be fraught with disaster. And obviously CPR in the prone position isn't particularly easy. It's labour intensive, and we have actually again recruited our anaesthetic teams to help move people into the prone position so that we can move away from the bedside, ask that the technical skill is performed by people who are experienced in doing this in a safe manner, but also so we can keep an eye on all of the other patients without being taken away on a single individual for half an hour plus. Next slide, please. These pictures are just taken from the Intensive Care Society guidelines. If we start at the top left, the pillows and support are placed on top of the patient with a sheet over the top, which is the bottom left. Next one along, the patient is wrapped inside the sheets and then eventually moved by 5 people over into the prone position. Next slide, please. The final product should, if you can move, that's it, the final product should look like that, and you can see that the elbows are clear, the abdomen is supported, and it's almost like swimming in the front crawl position. Next slide, please. I'm just going to focus on the head here. So the eyes are taped, so there's no evidence of corneal abrasion. The ET tube is visible throughout. The ventilated tubings are supported, and you can see that the hands are free. There's no compression at the elbow of the ulnar nerve, and there's full monitoring available. Next slide, please. If anybody's interested in knowing how to do this, there is a checklist or a lock-SIP that the Intensive Care Society have published. Next slide, please. So having looked at the respiratory support in these patients in some detail, we've talked about the non-invasive strategies, the need for early intubation and to try and avoid clinical deterioration and intubating in extreme situations. We've talked about different strategies for trying to improve hypoxemia, which includes application of PEEP and also prone positioning. What we found is for those patients that are improving and weaning, is that it's taking quite some time for these patients to come off a ventilator. And in the beginning, we were, I think, quite alarmed at the fact that relatively young, healthy people were taking a while to improve and to wean from ventilatory support. And I think in the beginning, we perhaps were a little bit overzealous in terms of trying to extubate patients, and we ran into difficulties with higher reintubation rates, and I know this has been shared by other centres, and there's been evidence of upper airway edema. We would normally use a spontaneous breathing trial to assess suitability for extubation. I think the important thing is that humidified circuits are used so that loosen secretions and also to try and stop thick secretions blocking up circuits. We would find that extubation occurs probably a little bit later than we would under normal circumstances, maybe a day or two later. And we've also found that patients tend to be quite weak at the time of extubation. And at the moment, I don't have data on critical illness polyneuropathy, but I think what we're seeing is some evidence of that in our population. Next slide, please. I'm going to move on now to the cardiovascular system and talk a little bit about the hemodynamic challenges with COVID. Often our patients, as I've alluded to, are intravascularly deplete for multiple reasons. I've talked about positive end expiratory pressure or continuous positive airway pressure can have an impact upon cardiac output. And the recommendations initially were run these people dry as part of the ARDS treatment. We know that conservative fluid strategies in ARDS have a beneficial outcome, but I think it's now accepted that we need to aim for euvolemia. There's high prevalence of shock in these patients, depending on which studies you look at, somewhere in the order of up to 35%. And I think it depends upon the population, the severity of illness, and how you would define shock. And certainly in terms of cardiac injury, there's a recognition that this occurs in about 23% of cases of shock, sometimes related to fulminant myocarditis. Next slide, please. I've just pinched these slides from a paper which is not yet published because I thought it gave quite a good overview of the reasons why patients may have myocardial dysfunction during time of COVID. The theme that spreads throughout most of the work on COVID-19 is the release of cytokines. And it appears that COVID-19 attaches to the ACE2 receptor and causes release of cytokines, predominantly interleukin-6, which can have a direct and indirect myocardial impact. The other thing that I've suggested is the impact directly upon the myocardium. And I think at the moment, this is only clinically suspected, and I'm not sure that there is evidence of any histological diagnosis of this. We've also, our cardiology colleagues that have been speaking earlier have talked about the myocardial infarction related to COVID-19. We know that there is inflammation and viral invasion which can cause plaque instability. And related to type 1 MI, but also we know that hypoxia in the inflammatory state can cause a mismatch between supply and demand and can contribute to type 2 myocardial infarction. And as we've mentioned earlier, the microangiopathy, we have a pro-inflammatory, pro-thrombotic state with high levels of D-dimer, which can have also an impact upon endothelial dysfunction. Next slide, please. So essentially, what do we do about this? I think the need for hemodynamic monitoring is key. Recommendations are that these are dynamic parameters rather than static parameters, and looking at capillary refill, regular lactate levels, skin temperature compared with core temperature, looking at venous versus arterial CO2 difference. Assessing intravascular volume is always quite tricky, and what we would we tend to do is very simple bedside tests such as passive leg raising, and I know earlier speakers have talked about point of care ultrasound. I think for intensivists who have this skill, it has been remarkably useful, and many of my colleagues have been doing point of care ultrasound on a regular basis for several reasons. First of all, lung imaging, looking for B lines, looking for evidence of consolidation, ruling out pneumothoraces if there's been high pressure ventilation. But from a cardiac perspective, actually just looking for ventricular filling, looking at responses to volume loading, and looking at cardiac contractility. And obviously within a critical care system, we have access to cardiac output monitoring, and certainly I feel that I probably have used this more frequently during the COVID epidemic, just to establish that we have adequately filled the patient, that we've adequately treated or helped with inotropes or vasopressors, based on measurements of cardiac output and systemic vascular resistance. Next slide, please. I just wanted to bring this slide in. This was, I think it was published a couple of days ago in the New England Journal of Medicine, and it was certainly something that we felt anecdotally we saw quite a bit of early on in the COVID crisis, was the fact that many patients were relatively young without major cardiac comorbidities, were having out-of-hospital cardiac arrests, some of whom didn't actually make it to the critical care unit. The blue lines were during out-of-hospital cardiac arrest during the 2020, compared with the case-controlled out-of-hospital cardiac arrests in 2019, and you can see that there's quite a significant difference. And if you look at the red line, that is the number of COVID-19 cases. So this is suggesting that there's more than a 50% increase in the number of out-of-hospital cardiac arrests, which I think we'll probably have more information as this crisis ensues. Next slide, please. Just wanted to talk a little bit about passive leg raising, which is one of the techniques that we use to assess intravascular volume. Normally the patient should be sat at 45 degrees. Most of our patients are at least 30 degrees head up in ICU anyway. And then we use the bed to adjust and to give a basic leg raising. This is almost like an auto transfusion or a fluid challenge, which is a reversible situation. If the patient is awake, then obviously it's important you explain to them what's happened. And then you look at the cardiac output as to determine what happens as you have passive leg raising. And if you get an increase of 10 to 15% in cardiac output, this is suggesting that this patient would benefit from fluid, and therefore you would deliver a volume bolus, normally crystalloid. Starches to be avoided, and reassess. And this is a quick, simple bedside test that you could do to establish intravascular volume status. Next slide, please. Just looking at the recommendations from the Surviving Sepsis campaign that were written particularly for the COVID epidemic, and this has been published with the evidence. As you can see in the right-hand slide part of the table, a lot of this evidence is quite weak. The only strong evidence is against the use of starches for volume resuscitation. Don't think any of this is particularly different to any of our previous practice. Next slide, please. I'm just going to talk a little bit about the cytokine storm, which is something that we have seen in some individuals. We're going back to just looking at the mechanism. The COVID virus attaches to the ACE2 receptor, which is predominant in lung epithelium, gut epithelium, and also in vascular endothelium, and causes release of interleukins and the inflammatory response that we've talked about. In some situations, we do see a hyperinflammatory response with release of IL-6, tumor necrosis factor, etc. Next slide, please. And what we have seen is this massive inflammatory response and cytokine storm with macrophage activation, and the net effect of that causes the prothrombotic state that many of us are witnessing. Next slide, please. The outcome of that cytokine storm has a multi-system effect, and you can see that it can produce shock. Acute kidney injury contributes to lung injury and coagulopathy, but also contributes to immune paresis and cell death, which ultimately would contribute to organ failure plus or minus death. So this cytokine storm syndrome we need to just supportive care. It usually involves getting the intravascular volume right, supporting the blood pressure with vasopressors, use of steroids for refractory shock if necessary, and making sure that we have dealt with the underlying problem, correction of hypoxemia, ruling out secondary infection. Next slide, please. As we're talking about infection, I just want to talk a little bit about the use of antibiotics. I think from the webinars that have been distributed from the Intensive Care Society and multiple learned colleagues, there's no concordance of opinion regarding antibiotic use. Certainly in our unit we use procalcitonin, a biomarker, to guide antibiotic therapy. And I think the other thing that we are seeing is later fungal infections, and we've seen 2 or 3 patients with aspergillus isolates, despite not having risk factors for this, and this is quite unusual. It's not something we would normally see in our normal population. Next slide, please. This slide is taken from the pro-rata study, which is nearly 10 years old now, and it's basically looking at procalcitonin to guide the use of antibiotics. We found it useful in our practice to discontinue antibiotics or to distinguish between infection and inflammation. Next slide, please. I'm now going to move on to acute kidney injury. Acute kidney injury is relatively common, as I alluded to earlier in the early part of the presentation. From the ICNARC data, our incidence is in excess of 20%. And obviously we see much more of acute kidney injury in a critical care setting. What we would tend to do is offer renal replacement therapy within the critical care unit, and we've seen obviously an increased risk of need for this with patients with significant comorbidities. Next slide, please. In terms of COVID-19, the things that contribute would be very similar to all of the rest of the disease processes, particularly hypertension, hypovolemia, hypoxemia, high airway pressures, pre-existing renal disease. But there is a concept that the virus itself can cause direct disease-related injury, and also the microvascular thrombosis that I have alluded to previously. Next slide, please. Most of you will be aware that we use continuous techniques in the critical care setting to essentially replace the function of the kidney while we support other organs and give the opportunity for renal recovery. Next slide, please. The 2 techniques that we tend to use, the continuous techniques, tend to be via convection and dialysis via diffusion. It's not particularly a problem in the critical care setting to offer either of these or combinations. Next slide, please. And this is essentially what it looks like in real life. One of the big issues that we've had is acquisition of hemodialysis replacement fluids. And again, I think because of the increased requirements globally, that supply of these has been difficult. And therefore we have relied increasingly upon our renal colleagues to provide intermittent hemodialysis to preserve stores of replacement fluid for those people who are so unstable they may not tolerate an intermittent technique. Next slide, please. Finally, I'm just going to allude to some of the neurological manifestations of COVID, and at the moment these are being recognised and supported. One of our first patients that we managed was a young patient who had a brainstem stroke, and we suggested that that was probably due to some anatomical abnormalities plus the microvascular thrombosis. Next slide, please. from early studies from Wuhan suggested that more than a third of patients had neurological problems. Presentation, this might be headaches, dizziness, anosmia, to stroke, as I've suggested. And also there are other case reports of critical illness, polyneuropathy, rhabdomyolysis, which certainly I have seen in young gentlemen who I've managed over the last 2 or 3 weeks, and Guillain-Barré syndrome. Next slide, please. Just to conclude this, I'm going to just talk a little bit about coagulopathy and COVID-19. It's very clear that severe COVID-19 infection is associated with both coagulopathy with features of DIC and thrombotic microangiopathy. And coagulopathy is a marker of adverse outcome. COVID-19 is a pro-inflammatory, pro-thrombotic disease process. Next slide, please. I'm just going to refresh. We've touched on this already about the ACE2 receptor and the cytokine response, which the prothrombotic state is largely due to the effects of IL-1 and IL-6. Next slide, please. And what we do see in terms of measurements is that once we have an acute lung injury, the pro-inflammatory state due to cytokine storm, activation of the endothelium and macrophages, we have an increase in ferritin, CRP, D-dimers and fibrinogen. The coagulation experts feel that this is this is related to a secondary phenomenon, secondary to inflammation and hypoxemia, rather than a primary thrombotic process. So the issues are to deal with the hypoxemia and the inflammation. Next slide, please. This is taken from Wuhan, and you can see, if you look at the diagrams on the right-hand side, there's a clear difference between the survivors in blue and the non-survivors, measuring D-dimer, interleukin-6 levels, serum ferritin, high sensitivity troponins, and lactate dehydrogenase. The lymphocyte count, which is generally low, tends to remain low in those patients who don't survive. And obviously lots of our patients who are sick and prothrombotic have increased risk of thrombosis anyway. Older, acute infective illness, the use of venous lines. Many of our patients bring in other risk factors, and of course they're immobile for many weeks, and maintenance of mobility during critical illness is actually quite difficult, particularly during the acute phase. Next slide, please. We've had lots of discussions with our haematologists about the best way to manage this prothrombotic state. I think from a haematology point of view, their recommendation is that we used weight-based low molecular weight heparin. If we have an acute deterioration in oxygenation, which is not explained by another means, then we have to think about, is this a pulmonary embolism? We would also have increased the dosing of tinzaparin from prophylaxis to therapeutic when we've run into difficulties with continuous veno-venous hemofiltration. And what we have seen is that we have lost many filters because of clotting. And this is quite unusual. So several of our patients have ended up requiring full anticoagulation just to perform continuous veno-venous hemofiltration. The rest of our systems in terms of management of hemoglobin, low platelets and coagulation remain unchanged. Next slide, please. So just to summarize, I think we have a multi-system disorder. I've talked about a little bit about the pathophysiology, but also taking you through the respiratory, cardiovascular, renal, neurological and hematological issues that we're facing. As I suggested in the beginning, we have lots of questions, probably don't have the answers. I think we're all gaining experience, but I don't think at the moment any of us could claim any expertise. It is very, very challenging. I'm now into my 15th year as a consultant, and I often feel quite uncomfortable as to what to do next. And I think one of the big benefits is, as a critical care community, is the unity, the support, the collegiate approach that we've had, and hopefully this will help us as we move forward. Next slide, please. And I have to end on the need for research. This is just a brief synopsis of some of the trials that are happening in our unit at the moment. And I think we will hopefully benefit from this experience, but getting some really good quality trials to support our practice is key. Next slide, please. And this is just down the road from where I work on a sunny spring day to say thank you very much for the invitation to speak. I hope I've given you an overview of COVID-19 from a critical care perspective, and I'm happy to join any further discussion. Thank you.
Thank you very much, Diane. It's such a nice, comprehensive presentation.